Good afternoon, everyone. So this afternoon, our topic is parasitology. This is a new topic in second year as recommended for basic pediatrics. So I will be discussing common Filipino pediatric parasitic diseases, okay? And I will focus on the transmission, incubation period, manifestations, diagnosis. And for treatment, I will be mentioning the drugs, but I will not focus on the dosages. So these are the learning objectives. And as well as this one. So we'll start with amoebiasis. And this is caused by Entamoeba histolytica. This is common in children in developing countries, okay? And the mode of transmission is through ingestion of cyst. Therefore, it is the infective stage. Inside the body, it undergoes a process until it becomes a trophozoite. And it's the one that causes cell damage, that causes inflammatory response, and hence the manifestation of amoebiasis. The cyst can be killed by heating at 55 degrees centigrade for 5 minutes. So boiling and cooking of food will kill the amoebic cyst. There are 3 species infecting humans, okay? Entamoeba histolytica is the main pathogenic species causing amoebiasis. The Entamoeba dispar is the most prevalent species but does not cause symptomatic disease, okay? It only causes asymptomatic disease. And we have a third one that may cause diarrhea in infants, Entamoeba moshkovsky. So this is just the pathogenesis of amoebiasis, okay? It starts with ingestion of cyst from contaminated food and water in the body. It undergoes a process and it becomes a trophozoite, and therefore it invades the mucosa and causes the manifestation of the disease. It's the pathogenic stage of the parasite. The host cells are destroyed by 2 mechanisms: cell lysis through the action of what's being released by the trophozoites, okay, and apoptosis, which is a process of cell death as well, and primarily brought about by influx of extracellular calcium by the effect of the amoeba as well. So for the pathogenesis, the E. histolytica trophozoite causes intestinal damage, and the body reacts by release of the inflammatory cells like your neutrophils, monocytes, and macrophages, and other mediators, leading to damage of epithelial cells. Now, for the epidemiology, there are about 480 million people infected with either your histolytica or dispar. And about 100 million of those infected with E. histolytica present with symptomatic disease. So still majority of cases of amoebiasis is asymptomatic. About 10% of individuals who have amoebiasis will develop into amoebic colitis. and less than 1% will present with disseminated disease. It is also associated with mortality. Amoebiasis is the second leading parasitic cause of death worldwide after malaria, which I will discuss later as well. So for the clinical manifestations of amoebiasis, as I have said earlier, majority of cases are asymptomatic, and they are also cyst carriers, and they pass out cysts, which become the source also of contamination of food and drink, and leading to infection of other individuals. Being asymptomatic, they should also be identified and be given proper treatment, because 10% of them will develop invasive disease within a year from incubation. And severe disease is more common in young children, pregnant women, malnourished, and those taking corticosteroids, and of course, those who are immunocompromised. Again, ED-SPAR is non-pathogenic, okay, does not cause symptomatic disease, and E. histolytica is pathogenic in majority of cases. Amoebic colitis may occur within 2 weeks of infection, okay, following symptomatic invasive amoebiasis. There could also be hepatic amoebiasis, and extraintestinal disease may also involve the brain, causing abscess. So the primary complaint of children with amoebiasis will be diarrhea, common in young children because of the mode of transmission is through fecal oral, and the very important source here will be the poor hygiene, okay, and contamination of the food and drink. Amoebic colitis in infants and young children tends to be rapidly progressive, okay, with more extraintestinal involvement and associated with high mortality. These are the manifestations, okay. Aside from diarrhea, there is pain and other and the absence of constitutional signs and symptoms. For young infants, pain will manifest as fretfulness or irritability. The following are the possible complications of amoebic colitis or intestinal amoebiasis. Okay, we have the necrotizing enterocolitis, amoeboma, which is sometimes developed into chronic amoebiasis. Okay, it's a granulation tissue formation in the bowel with an apple core appearance. They can also have megacolon, peritonitis, leading to perforation and extraintestinal extension. Hepatic amoebiasis is a very serious manifestation of disseminated amoebiasis, okay? It may appear in patients with no history of intestinal disease, and death may result from ruptured abscess in the peritoneum, thorax, and pericardium. The trophozoites are found in the walls of the abscess, and the right lobe of the liver is involved more commonly than the left lobe. The hallmark of hepatic amoebiasis is fever. Okay? Some may have jaundice. And this occurs in less than 1% of patients with intestinal amoebiasis. So this is a rare complication of intestinal amoebiasis. Changes at the base of the right lung may occur, such as elevation of the diaphragm if there is hepatic abscess. There could also be atelectasis at the right lower lung, or effusion or parenchymal compression. Thoracic amoebiasis is the most common type of extra-abdominal amoebiasis. It occurs in 10% of individuals with amoebic liver abscess. It can present as empyema, bronchopleural fistula, or even pericardial amoebiasis. Cerebral amoebic abscess may occur in 8% of those with amoebic infection. Okay? The trophozoites hematogenously spread into the brain or meninges. Okay? And there will, of course, be neurologic signs, but these are not assessed easily since the patient is too ill with the primary disease in the intestine or the liver. So other complications of hepatic amoebiasis or amoebic liver abscess are your peritonitis, pneumoperitoneum, or even perianal fistula or ulcer. So how do we diagnose amoebiasis? So e-histolytica antigen detection distinguishes your e-histolytica from e-dispar. Okay, so we can have an antigen test. We can also have fecalysis with microscopic examination of the stool that's been submitted within 30 minutes of passage. But microscopy does not differentiate histolytica from dispar, except if there will be findings of phagocytosed erythrocytes, which is characteristic of e-histolytica. Other diagnostic measures will be through biopsies and endoscopy. Okay, another one is indirect hemagglutination test, showing a titer of at least 1:128. So this is a 2-specimen collection showing an increase in the titer. It's possible like that. Okay, PCR is the most sensitive method to distinguish histolytica from dispar. Other indirect findings will be, of course, leukocytosis, anemia. For hepatic amoebiasis, there will be elevated liver enzymes and inflammatory markers and ESR. Radiographic findings may show elevation of the hemidiaphragm on the right. And on ultrasonography, we will have an echo-free area on the right lobe. And in majority of these patients, they have normal stool exam. Now, we also do liver scan to diagnose or to suspect your hepatic amoebiasis with findings of non-visualization of a particular area. And you can have your CT or MRI scans, and they have your single cavity in the right hepatic lobe. There could be needle aspiration of the liver abscess, but there could be complications with this invasive procedure, like bleeding, peritoneal spillage of the pus, and secondary bacterial infection. So we also treat asymptomatic cyst carriers. Okay, so being asymptomatic, then maybe for high risk, we do routine fecalysis. Okay, especially for those who will be working in restaurants, they should be screened. And being carriers and asymptomatic at that, they still need treatment. So we can give paromomycin, iodoquinol, or diloxanide furoate. Okay, these are luminal amoebicides. But diloxanide furoate is recommended only for 2 years and older, not for younger infants. So for invasive amoebiasis, we usually give metronidazole, and this is followed by giving luminal agent like diloxanide furoate. For fulminant cases, aside from giving metronidazole, we also add the dihydroemetine as part of the treatment. Now, surgical management may also be required if there is intestinal perforation and toxic megacolon. Okay. Invasive amoebiasis is treated with, aside from metronidazole, we can also give as alternative tinidazole, and still followed by luminal agent. So aspiration of large or left lobe abscess is needed for the following. These are the indications. If the abscess is more than 12 centimeters diameter, and there is already, with this size, there is already danger of rupture of the abscess. Location of the abscess, usually it's in the right, but being in the left lobe, there is risk of pericardial rupture adjacent to that, and hence would require aspiration as well. For late diagnosis, if already ruptured, okay, and if we want to exclude pyogenic abscess, that would require a different antimicrobial and will affect your management, and you really have to have aspirate of that abscess for culture. And also, following poor response to amoebicidal drug after 4 days, there could be a need to aspirate and send for culture to be guided for the etiologic agent, or if there is resistant organism. So most infections evolve to either becoming asymptomatic carrier state or full eradication and healing. Still, mortality is associated if there is extraintestinal involvement. Now, early diagnosis and the need for surgical intervention, if there is an indication, will decrease mortality rate from 28% to a reduction of 100%. And the case fatality rate increases from having liver abscess to cardiac involvement to CNS involvement. It's preventable, and primarily through proper sanitary measures, and in particular, avoiding fecal-oral contact. And we need to screen the sources of this infective stage, the cysts. Okay, we identify the asymptomatic cyst passers. Okay, and following treatment, we should repeat the stool exam until we get a negative result after completion of treatment. To identify cyst carriers and to treat them properly. Now we go to your giardiasis, caused by Giardia lamblia or Giardia intestinalis or duodenalis. Okay, again, the same infective stage as amoebiasis, which is the cyst. Okay, so it is passed in the stools, and it is also the infective stage. Okay, but it can also be inactivated by boiling. So really, proper cooking of food and boiling of water and hand washing will really prevent these common parasitic infections, which can be fatal. So it has a worldwide distribution, the giardiasis, and in the US, the prevalence is about 20%. And it's considered the main cause of diarrhea outbreak associated with drinking water. Okay, that's giardiasis. So 2 million individuals are currently infected. And again, the age prevalence is high during childhood and it declines after adolescence. Just like in amoebiasis, there could be asymptomatic carriers of your giardiasis. So we have identified the high-risk groups for giardiasis, and these are the following as listed. Now, there is higher incidence in patients with cystic fibrosis due to increased production of mucus, in these cases, protecting the organism. So other reasons for being high risk are self-explanatory: immune deficiencies, okay, those in institutions, travelers to endemic areas as well. So humoral immunodeficiency. Of course, any immune suppression or immune deficiency predisposes to almost any infection. Okay, in this case, also to chronic symptomatic Giardia infection. Infants can have partial protection from the IgA antibodies from breast milk. And the usual source of infection are the asymptomatic cyst passers. It has an incubation period of 1 to 2 weeks. So after ingestion of the cyst, patient may become symptomatic after about 1 or 2 weeks. Just like in amoebiasis, majority are asymptomatic. And for those with symptoms, onset may be abrupt or gradual. And again, diarrhea is the most common presentation. So for symptomatic giardiasis, they have diarrhea. They may have non-specific associated signs and symptoms, okay? And it's a non-bloody diarrhea. Now, especially for immunocompromised, they may progress to chronic giardiasis, and they will present with these findings. So it may even cause weight loss and malnutrition, as well as decreased cognitive function. So definitive diagnosis is finding of trophozoites or cysts or a positive antigen in stool or from duodenal specimens. Stool should be examined immediately, and we can have your stool enzyme immunoassay or direct fluorescent test also, which is a drug of choice for Giardia. So several specimens may be needed for higher sensitivity in diagnosing giardiasis. An enteroc test is more sensitive than a single stool exam. Okay, it's also called the string test. Okay, how is this performed? So the child is asked to swallow a string, and when the string is pulled out, it is examined under a microscope to look for the parasite. So duodenal biopsy should be considered in patients with characteristic manifestations and negative initial diagnostic tests, okay, but with supportive radiographic findings, plus supporting conditions of lactose intolerance, achlorhydria, absent secretory IgA or hypogammaglobulinemia, okay? So being immunocompromised as well. So we can do biopsy of the intestine and assays for specific fecal antigen. So aspiration or biopsy of the duodenum should be considered in patients with chronic symptoms, characteristic manifestations, and one or more radiologic findings. So for blood counts, they are usually normal and without eosinophilia. So these are the treatment for either acute or chronic giardiasis. And asymptomatic carriers are generally not treated except in outbreak control, prevention of household transmission to pregnant women, and patients with hypogammaglobulinemia or cystic fibrosis. So those are the indications and the drugs of choice. So we usually give metronidazole or nitazoxanide or tinidazole, okay? The dose is based on age, okay? And the duration is based also on the drug being given, okay? For tinidazole, it could be a single dose. So other management of giardiasis will include electrolyte deficiency management, management of dehydration. If there is concomitant lactose intolerance, then we shift the milk to a lactose-free milk. And again, since the source of cyst will be contaminated food and water, then we have to clean this properly or boil even the water for consumption. And follow up closely for possible relapse. So most infections, just like with amoebiasis, in giardiasis will either lead to being asymptomatic carriers or being totally healed. And it also has extraintestinal infection that carries about a 5% mortality. So your parasitic infections can really cause death. So the same preventive measures for giardiasis and amoebiasis. Now let's go to malaria. It's also a protozoan illness characterized by primarily fever. And you have other manifestations like fatigue, pallor, and splenomegaly. And it's caused by intracellular Plasmodium protozoan transmitted by mosquito bites, okay? So there were 4 species before 2004. There are falciparum, vivax, malaria, ovale, and in 2004, identified in several Asian countries will be your knowlesi, okay? Malaria is a major worldwide problem with principal areas of transmission in Africa, Asia, and South America. Plasmodium vivax and falciparum predominate in Southeast Asia. And malarial deaths in areas of high malarial transmission occurs primarily in children less than 5 years of age. But in areas of low transmission, there is a large percentage of death in older children and adults, okay? So in worldwide, there are more than 200 million cases with almost 500,000 deaths reported in 2015, okay? So it is transmitted through the bite of an infected female Anopheles mosquito. And it can also be transmitted through infected blood during blood transfusion and use of contaminated needles or other drug paraphernalia. It can also be transplacentally transferred, okay? And even during the birth process, okay? It can also be transferred through blood from the infected mother, maybe during the birth process. It may lead to neonatal malaria. So the degree of damage to the tissue depends mainly on the parasite concentration, okay? Like for example, for ovale, vivax, and malariae, less than 2% parasitemia, and for falciparum, more than 60% parasitemia. So of course, you have fever, and this occurs when erythrocytes rupture and release merozoites in the circulation, with consequent anemia following that hemolysis, and sequestration of red cells in the spleen and other organs, and suppression of RBC production. So there is marked amplification occurring in humans. First, it is in the hepatic cells, your exoerythrocytic phase, and then second phase is in the red cells, your erythrocytic phase. So your tumor necrosis factor is responsible for most of the pathology of your malaria, okay? So there is excessive production of cytokines, pro-inflammatory markers in response to the trophozoite invasion. And it leads to tissue anoxia because of adherence of infected red cells to the endothelium, okay? Most often due to your falciparum. And it can cause obstruction of blood flow and capillary damage. Now, unfortunately, following infection, immunity is incomplete, okay? And there could be repeated episodes of malaria because of immune evasive strategies like the following, okay? Intracellular replication, cytoadherence, variations, and alteration of the host immune system. Now, it has been studied that Plasmodium falciparum is resistant to RBCs with hemoglobin F and to sickle erythrocytes. Hence, those with sickle cell anemia appears to be protected from acquiring malaria due to Plasmodium falciparum. And depending on the etiologic species, then the incubation period varies from as short as 9 days to as long as more than a month. So incubation period can be prolonged for those with immune suppression. So the malaria will present initially with prodromal symptoms of non-specific manifestations, but sometimes with chest pain and joint involvement, okay? And these are seen 2 to 3 days before parasites are seen on smear. So during this period, they will not yet be confirmed to have malaria. But during the febrile paroxysms, which coincides with rupture of schizons, then there could be a pattern of paroxysm of high fever, but not always the case. And these are the manifestations associated with febrile paroxysms, generally non-specific. And therefore, children with malaria may have non-specific symptoms with high index of suspicion on our part. So there are 2 groups of children with malaria, the non-immune and the immune child. An immune child has high degree of tolerance against falciparum by 10 years of age. But of course, the non-immune child has higher risk of severity of the disease if untreated. So in a non-immune child, there could be sudden or gradual onset, okay, with fever and other manifestations, plus specifically splenomegaly, pallor, hepatomegaly, and they can have decreased platelet and will manifest with cyanosis. So these are the 10 complications of falciparum malaria, okay? Severe anemia due to red cell hemolysis, cerebral malaria, which is associated with a high fatality rate, okay? Of course, respiratory distress, CNS manifestation such as seizures, and the consequences as well of hypoglycemia, which also includes seizures or shock. And unfortunately, again, it's associated with high morbidity, long-term cognitive impairment, okay, which occurs quite frequently, 1 out of 4 children with cerebral malaria, okay, or those with repeated episodes of even uncomplicated malaria. Additional complications are the following. And renal failure, acute renal failure, which could be pre-renal, and other complications. So when we suspect malaria in a patient who comes from an endemic area, okay, presenting with fever or chills, or sometimes late presentation of decreased level of consciousness, there could be pallor, splenomegaly. Okay, so blood smears are taken, and if confirmed, we identify the species. Okay. The concentrations of RBCs on a thick smear is 20 to 40 times than in the thin smear, and it is used quickly to scan large number of red cells. So we need the thick smear, while the thin smear allows for identification of the species, and it's useful in following response to treatment. So we submit both thin smear and thick smear of blood. So we have to have high index of suspicion if they are coming from endemic areas for malaria, or there is a history of blood transfusion, or the patient is a drug user. So these are the criteria that suggest Plasmodium falciparum malaria, okay? After returning from an endemic area, less than a month, okay? So it fits to your incubation period, and then maybe findings of RBC infected with more than one parasite, okay? For uncomplicated, asymptomatic malaria without signs of severity or evidence of vital organ dysfunction. That's our definition of uncomplicated malaria, okay? They may be asymptomatic, okay, or with evidence of vital organ dysfunction. And the rationale for anti-malarial combination therapy is that it's more effective and it prevents or delays the emergence of resistant parasite. So these are some of your combination treatment for malaria, as well as the duration of the treatment. So I will not focus much on the treatment. Other drugs for malaria. Okay. Okay, some of the drugs are based on the weight. The duration varies as well. And if there is high index of suspicion and other clinical manifestations, then treatment may be initiated whether the disease is confirmed or not yet by a test. So coming from areas of endemic for malaria, and you have the manifestations of fever, and you have hepatosplenomegaly maybe, okay, and other findings, pallor, and this will make you highly suspect malaria. The drugs also have their side effects, okay? And we identify if the malaria of the patient is one that is chloroquine susceptible or resistant, so that will guide us in our management. So for severe malaria, we can give quinidine gluconate or quinine dihydrochloride, okay? And then, as recommended in Nelson, you can have your drug for chloroquine-resistant falciparum or even parenteral management based on this criteria. Now, for CDC guidelines for the treatment of malaria, okay, so the drug of choice is still chloroquine, okay? If there is chloroquine resistance, it is considered if the parasite count does not drop rapidly within 24 hours of initiation of treatment, and if the parasite count does not become negative after 4 days. So we consider chloroquine resistance and shifting the drug. Okay. So individuals traveling from areas with chloroquine susceptible falciparum can still be treated with chloroquine, okay, if they do not have severe malaria. Uncomplicated malaria caused by other plasmodium can be treated also with chloroquine, okay, as long as the area is chloroquine susceptible. Now, we also test for G6PD deficiency, okay? It must be performed before initiation of primaquine because it can cause hemolytic anemia in such patients. So we are careful with the treatment of the drug in the presence of an underlying G6PD deficiency. Okay, so other combinations as recommended by CDC. So the following are supportive treatment. Of course, they could be in shock. Okay, there are electrolyte imbalances. Okay, we want to decrease the high fever. Okay, is there hyperglycemia or hypoglycemia? Okay, is there acute kidney failure? Okay, that would warrant dialysis, and maintaining and preventing seizures. Okay. So to prevent relapse, we have these drug recommendations. And to destroy or sterilize gametocytes, we have this treatment recommendation. So of course, since it's mosquito-borne, avoidance is recommended, or application of repellent or a repellent sticker, the use of screens, and proper killing of the mosquitoes, or even the use of mosquito nets. There are preventive measures which are good, okay, preventive measures for malaria, okay, but it must be planned because some had to be taken a week or 2 before departure, okay. Now, when there is chloroquine-resistant falciparum, then we have alternative drugs to be given, okay? There are poor prognostic signs for severe malaria. Okay, the age, the duration of the seizures, neurologic findings of the cerebral posturing, absent corneal reflux, hyperparasitemia, leukocytosis, and severe anemia. Each one of these is a poor prognostic sign and must be prevented or addressed. Other poor prognostic signs are the CSF findings, hypoglycemia, acidosis, okay, liver enzymes. So it's a multi-organ shock and involvement. So indications for admission are the following. Okay, self-explanatory now. And the manifestations of severe malaria are the following. Okay, there is severe anemia. Okay, poor urine output. So you have multi-organ involvement, seizures for your CNS. Okay, and you have your hypoglycemia, metabolic acidosis. Okay, and these are the manifestations of severe anemia. Now we go to your filariasis. Okay, it's caused by either Wuchereria bancrofti or Brugia malayi. Okay, and it also affects more than 100 million of people in 80 countries. Okay, and 80% of the population in endemic areas may be infected. That's how high it is. That's why you will see the preventive measure later could be the treatment of the entire community. And less than 10% have clinically significant morbidity. So a majority of them are not as what we will see them. Okay, only less than 20% have clinically significant morbidity. So these are the areas where the disease is prevalent in the provinces, okay? And the sources will be, of course, the infected persons, okay? It is also transmitted by a mosquito after biting an infected person, and then again, biting another one. Another mode of transmission is blood transfusion, okay? There are different species of the mosquitoes that carry the parasite, the infective stage, okay? And the incubation period could be months to a year, okay? So it may be difficult to identify the source. For asymptomatic microfilariae, usually often develop in children in endemic areas, so they are asymptomatic. Others may have acute manifestations in older children, particularly inflammation of the lymphatic system, aside from the nonspecific systemic signs like fever, headache, and myalgia. So why is there specifically involvement of your lymphatics? These are due to acute inflammatory reaction triggered by death of adult worms, okay? So there will be hydrocele and elephantiasis, which are the main clinical presentation and occurs mostly in adults. And this results in fibrosis, leading to obstruction to flow, hence the accumulation of the fluid. They could present with epididymitis, orchitis, and chyluria, okay? And this can lead also to bacterial superinfection, okay? We can also have the tropical pulmonary eosinophilia when it involves the lungs and lymph nodes, but not in the bloodstream. Also common in adults. And of course, we have identified the endemic areas and the nonspecific manifestations and respiratory manifestations. There could also be tropical pulmonary eosinophilia, okay? and there will be interstitial fibrosis and leading to chronic respiratory insufficiency. Okay, you still have elevated IgE, you have eosinophilia, okay, and you see the diagnostic criterion could be your clinical response to the drug of choice, which is diethylcarbamazine, okay? So coming from endemic areas, okay, with cases of elephantiasis, okay, with respiratory manifestations, with eosinophilia, then this is highly suspected. And we can get blood to test for detection of the parasite antigen, okay? And there is a timing of blood collection, okay? Because microfilariemia is nocturnal, okay? So we diagnose it through antigen identification, and we have your ELISA tests as well, okay? Plus eosinophilia, and your elephantiasis can be diagnosed clinically. So the gold standard is the circulating filarial antigen detection test. There are specific drugs for the treatment of filariasis, with the drug of choice being diethylcarbamazine. Okay, there could be repeated doses to decrease microfilariemia in the blood and to kill lymphatic dwelling parasites. And again, the drug has adverse effects, okay, which can be confused with the clinical manifestations of filariasis. There could be other non-specific treatment, non-antiparasitic treatment for filariasis, which includes the following: addressing allergic reactions with antihistamines or steroids, maybe a need for surgical excision, okay, and some supportive management, and even plastic surgical repair of genitalia that's involved. And there, as I've said earlier, there could be superimposed secondary bacterial infection and must also be treated as well. And for lymphedema and elephantiasis, the following other supportive treatment, these are recommended as well, okay? Of course, raising it at night, maintaining it to be clean and uninjured without trauma, okay, by keeping the nails clean, wearing, well, it's hard to have these well-fitted shoes, but at least to protect it from injuries, and appropriate immediate treatment for any abrasions or wounds, okay? Again, knowing the mode of transmission being through insect bite, and we can prevent it through control of mosquito population, treatment of carriers or of the entire community because of high endemicity. The target has been set a few years back at the time of COVID-19 pandemic, okay? And this was attainable by giving a single annual dose of diethylcarbamazine with albendazole for 5 years to all patients, to all individuals in endemic areas. So it's a public health issue. So just some pictures. Now we go to your pneumocystis jirovecii or jirovecii, okay, pneumonia, okay. In immunocompromised persons, this is of course life-threatening. And in the other end of the spectrum, for the immunocompetent, it could be subclinical, okay. So infections are from a new or repeat acquisition of the organism rather than reactivation of latent organism. Okay, Mode of transmission, the incubation period, habitat, these remain unknown. What is Pneumocystis girovesi? Okay, this is a common extracellular parasite found in the lungs of mammals. Okay, the DNA has genomic homology closer to fungi, but the morphologic features and susceptibility to drugs are similar to protozoa. So they infect young children. A healthy host is said to be asymptomatic, and an immunocompromised host develops pneumonia. Okay. 40% of infants and children with AIDS and majority of adults with AIDS, okay, are affected, or those with organ transplants. So these are the immunocompromised patients. And there is increased incidence of this type of pneumonia if the CD4 is markedly decreased. So there are two forms, cysts and trophozoites again, okay? Which they have special predilection to your alveolar epithelial cells and alveolar macrophages. It could be infantile or diffuse desquamative alveolar disease, okay? In infantile, it affects young infants and with prominent plasma cells, which is absent in diffuse desquamative alveolar disease, and which often affect older children and adults. So for infantile form, the onset is usually subtle, while for sporadic form, it is abrupt, okay? And in sporadic, the cases occur in children and adults with immune deficiency resulting from immunosuppressive medications. So the clinical manifestations of immune restitution inflammatory syndrome, or IRIS. These are manifested usually in patients newly diagnosed with AIDS and with concomitant pneumonia. Upon starting with antiretroviral therapy with rapid response, there is paradoxical deterioration associated with return of immune function. So there is a shift from anti-inflammatory state to pro-inflammatory state following HIV treatment. So the definitive diagnosis is by demonstration of the parasite in lung tissue. So we get specimens through lavage, aspiration, or biopsy, or bronchial brushings. So they could be identified through use of Grocott-Gaumont stain to identify the cyst of this Pneumocystis species. Okay. Serologic tests for this particular parasite is not useful. So the drug of choice is a common drug, your trimethoprim sulfamethoxazole. And the duration is also affected by concomitant AIDS disease, okay? Again, as with any drug, you have side effects or adverse reactions. Other alternative drugs are listed. And it has been shown that survival is better in moderate to severe cases if also given corticosteroids together with the antiparasitic drug of choice. And look at it, most complications are associated with the drugs rather than with the disease itself, okay? And in immunocompromised states, this type of parasitic infection can be fatal. So, of course, chemoprophylaxis is indicated for immunocompromised patients at risk of death, okay? So, those at risk should be identified, those immunocompromised, and be given chemoprophylaxis. And trimethoprim is the drug of choice, okay, given to these patients. Now we proceed to ascariasis. Okay, this is caused by Ascaris lumbricoides, which is one of the 3 major intestinal nematodes. The other 2 are your trichuris and hookworm. Okay, it occurs globally. Okay, and it is most prevalent among the human helminthiasis worldwide. Okay, with about 1 billion cases of ascariasis, okay? And there is high prevalence in areas with poor socioeconomic conditions and those that use human feces as fertilizer. It is common in areas with warm climates like the Philippines, okay? Ascaris eggs can even remain viable at 5 to 10 degrees centigrade for as long as 2 years, okay, given the appropriate environment. So the incubation period for this is 2 months, okay? And mode of transmission, like with other parasites, will be hand to mouth, okay? So they could be asymptomatic as well, which is the classic features of parasitic infections. They can be asymptomatic. And more with clinical manifestations of respiratory or intestinal or biliary tract involvement. So for your pulmonary ascariasis, it resembles Loeffler's syndrome and includes transient respiratory symptoms such as cough, blood-stained sputum, and eosinophilia. Larvae may be observed in the sputum, and a more serious complication occurs when a large mass of adult worms causes acute bowel obstruction. Okay? In intestinal ascariasis, the adult worms are in the small intestines, and the child presents with colicky, periumbilical pain. They may also have vomiting, abdominal distension, and cramps. In some cases, worms may be passed in the vomitus or stool. And the peak age of incidence is 1 to 6 years of age. It has an acute onset and may present with nausea, vomiting, and fever. So complications include obstruction, steatorrhea, and chronic infection that may affect physical fitness and cognitive development. Look at this image of a parasite infestation, post-operative picture of a section of the intestine that's resected from a 5-year-old with more than 400 roundworms, your Ascaris lubricoides, causing obstruction. So stressful conditions stimulate adult worms to migrate and lead to even biliary tract obstruction, and this will be an emergency situation, jaundice, appendicitis, peritonitis. And even the dead worms can serve as a nidus for stone formation. So we confirm Ascaris ova and worm in the stool. X-ray may show dense spaghetti-like strands. Okay, there is eosinophilia as well. And look at it, a gravid female worm, adult that can produce 200,000 eggs per day. And they can live for 1 to 1.5 years. And even in ultrasound, the adult worms can be visualized. So treatment, the drug of choice is albendazole. And you have other alternative treatment for ascariasis. Now, usually treatment is medical, but a referral to a surgeon for intervention may be needed for severe obstructive cases, plus correction of fluids and electrolyte imbalances in the presence of GI tract obstruction. So preventive measures will be mass deworming every 3 to 6 months and good sanitation. So prognosis is generally good as long as it's not late, leading to surgical intervention. So that's an example of an ascaris. And the barium studies that demonstrate worms as long linear feeling defects because barium was ingested by the worms and may be seen in their intestinal tract as a long string-like white line. So it's like a tram track appearance, okay? Highly suggestive of ascariasis. Now to your hookworm infection, which includes ancylostoma and necator. And they penetrate the body through the skin, okay? As well as ingestion of contaminated drinking water or soil pica. So incubation period will be weeks to months, and they are communicable as long as the eggs are in the stools or as long as the larvae are in the soil, okay? So it's a cause of major morbidity because of direct intestinal blood loss, okay? It also causes pallor to the person affected. So it can cause anemia and hypoalbuminemia and even lung lesions during lung migration of the larvae. So again, majority are asymptomatic. So you have noticed that majority of parasitic infections are asymptomatic, but with a small percentage presenting with symptoms and even complications. Since it enters through the skin, it starts with dermatitis or a ground itch. It could just be a pruritus on the skin, and eventually you will appreciate papule and disappears within a week, okay? Subsequent exposure may lead to vesicular formation and edema, okay? So intestinal hookworm infection manifests with any or a combination of this, okay? Anorexia. Parents will complain of poor appetite. So does a child have parasitic infection before I prescribe multivitamins and milk formula with high calories? Do that, okay? For the infantile ancylostomyiasis, this is due to ancylostoma duodenale and presents with diarrhea, melena, and unfortunately, malnutrition if with significant weight loss. So, of course, definitive diagnosis is we identify the eggs in the stool, okay? So your ancylostoma. And specific treatment could be albendazole or mebendazole. So mostly they have the same drug. And therefore, if you treat it, then you will be eradicating several parasites, plus supportive management, significantly of blood transfusion. And prevention will be always good sanitation and health education and avoidance of human feces as fertilizer. Enterobiasis is caused by Enterobius vermicularis, peaks in children and adolescents, humans being the only natural host, okay? So it infects 1/3 of children worldwide, okay? And they can have chronic parasitism due to repeated cycles of reinfection. So mode of transmission is hand to mouth, okay? And these are the pathogenesis of the enterobius. Often, again, they are asymptomatic. And for those symptomatic patients, they have nocturnal anal pruritus, sleeplessness, disturbances, allergic reaction to the parasite. So eosinophilia is not observed in this group of patients, and we diagnose them through finding of egg or adult worm in the perianal area, or detection of ova using an adhesive cellophane or tape. Okay? Few cases recovered from other parts of the intestines and genital tract of the females. So treatment for this parasitic infection is albendazole or even mebendazole. And again, repeat every 3 to 4 months as recommended as well. And morning bathing removes a large portion of the eggs as stated. So prevention could be mass treatment in institutions, handling of contaminated clothes, infected persons, handling the food, hygiene, okay? And household contacts can be treated at the same time. Paragonimiasis, okay? Caused by Paragonimus westermani, affecting 20 million people worldwide, with this distribution in Africa and in Asia, as well as locally in the Philippines, common among adolescents. And the source will be sputum and feces of man and animals. So this is through ingestion of raw, pickled or improperly cooked freshwater crabs or crayfish, which we love, okay? Infective stage is the metacercaria, and the final habitat is in the lungs. So the adult worms encapsulate in the lung parenchyma and deposit the brown operculated eggs that pass into the bronchioles and expectorated by coughing. Okay, so that's how it becomes also a source of infective organism. So most, again, are asymptomatic, and those symptomatic children have focused respiratory manifestations, plus CNS manifestation as well. So extrapulmonary symptoms are rare, but may involve the CNS particularly. So we find eggs in the stool or sputum smears with marked eosinophilia, okay, and treatment is praziquantel, and avoidance of eating raw or improperly cooked freshwater crabs, which is the usual habitat of the Paragonimus. And lastly, we have your scabies caused by Sarcoptes scabiei variant hominis, okay? And the sources are infected individuals and their personal effects like brushes and towels. So mode of transmission is direct contact. Okay, and the period of communicability could be 4 to 6 weeks, and if with previous infestation, 1 to 4 weeks only. So the first sign will be a red papule, okay, progressing into a barrow, and intense pruritus at night is the common complaint here. It has preferred sites like the face, the scalp, palms, and soles. Okay, and older children and adolescents will involve their interdigital spaces, wrist flexors, and other fold areas there. Sparing the head, neck, palms, and soles. And you have the complications. It could be bacterial or non-infectious complication. And we demonstrate the mite, ova, and sibala in epithelial debris. So we have specific treatment for scabies, which needs reapplication after day 1, okay? And non-specific treatment like to address the pruritus, to address secondary bacterial infection. That's a drug that we give. And preventive measure will include entire family being treated and use of clothing, bed linens, and towels. And these should also be washed in hot water. Okay, thank you very much for listening.